done from anterior side with some added advantage, which I'll be discussing. So I'll be discussing two approaches. In fact, there are three anterior approaches: transnasal endoscopic, transoral endoscopic, and transcervical. I'll be dealing with transcervical approach first, and then transoral with fusion in a single sitting from anterior side. And briefly, I'll talk about the endonasal approach, which I do not do, and I feel that it is, except for some situation, it is not required. So the approaches for craniovertebral junction can be from the posterior side, as it is shown here. For anomalies, craniovertebral junction anomalies like atlantoaxial dislocation or basilar invasion, the basic pathology is at the facet joint. So the facet joint can be approached from posterior side, as it is being done now by most of the neurosurgeon, and it can also, the same thing can be done from anterior side, as shown in the green arrow. And the anterior approaches could be transoral, transnasal, and transcervical. The disadvantage of transoral and transnasal approaches are that there is some risk of infection, especially if you plan a fusion. So this is little disadvantage, but in transcervical approach, this problem is not there, because you go through the sterile area. There can be situations people have suggested, because in fact there were anterior and posterior approach, and most anterior approaches were only for either a release of contractures or decompression, and then the posterior fusion was done from posterior side. So there can be both anterior and posterior fusion, in which transoral or transnasal decompression was done when you cannot satisfactorily treat this anomaly by posterior approach, and the fusion is done from the posterior side. But in the anterior approach, you can address both dislocation by manipulating the facet joint, and if, by the way, because of some pathology, it is not being reduced satisfactorily, in that case, in the same sitting, from the same approach, you can go for decompression. You can take out the odontoid process and part of the C2 vertebral body, and the fusion also can be done by the same approach. So it has an additional advantage, but there are, you need to select patient carefully. So what are those cases? Transcervical approach is especially useful for anomalies which are difficult to completely reduce by the posterior approach. This is one thing, and now I don't go for any posterior approach for last 3-4 years, except when the lesion is lying posteriorly. So, I mean, the things can be, the one school of thought are saying that you can do everything from posterior side. I say that you can do almost everything from anterior side. But the problem in transcervical approach is that the C2, C3 disc space is at or below the angle of mandible, because it comes in the way. The angle of mandible comes in your way when you operate, and it is little oblique approach. So especially for irreducible lesions and some lesions which are very, very difficult, even under GA and manipulation of the joint, you cannot reduce them completely. So what are those factors or those lesions which cause irreducibility in AAD? When there is a tissue in between C1 arch and odontoid process, so if it is fibrosis or a callus, obviously you cannot reduce, irrespective of whatever amount of force you use. If there is a C1, C2 fused joint also, then complete reduction is also not possible. At times, because of the chronic pathology, there is a contracted tissue, very thick contracted tissue anterior to C1, C2, which causes difficulty in reduction. There may be malunion with fibrosis or callus formation that also prevents, and at times there is an injury of facet joint. So if there is an injury to the facet joint, you cannot manipulate the facet joint. So anterior decompression is required in that case. And when preoperatively you don't find any movement at all, or if there is less than 50% reduction, then these patients are likely to continue with the compression. And therefore, in such cases, I think it is better to go from anterior approach. The oblique C1, C2 joint also prevents manipulation of the joint, and these cases also may require anterior approach. So because in anterior approach, you can do both decompression and fusion. So if it is not completely reduced, then you decompress also. If it is reduced, then you just fuse it. When there is a severe anterior posterior dislocation or cranial dislocation, then only a limited portion can be reduced. So these are the cases in which you have to go. Or if the surgeon is not expert in posterior release, there are some little bit of problem like bleeding, but I don't think that is a severe any factor in not doing posterior approach. So, but if you are not interested or reluctant to operate from posterior side, then anterior approach is an alternative. So these are some of the examples. On left side, you find that C1, C2 facet joint is fused. So this causes difficulty in reduction. There may be a callus in between the odontoid process and the fracture odontoid, which is attached to C1. So this callus prevents the correction of dislocation. And once you cannot do it, so therefore, by any mean, you have to take out this callus so that this comes back posterior. So you have to go from anterior approach in certain percentage of patients. What are the advantages of endoscopic trans-cervical? The trans-cervical approach also has been described open approach way back, and it is being practiced by many neurosurgeons. The endoscopic approach, as you know, allows a very small incision, and because you don't have to open up more, therefore it is better, the less morbidity, and hardly any tissue mobilization is required. It is almost in an avascular plane, and the other advantage is both decompression and fusion can be done. So if you are not able to reduce, then you can decompress also and do the fusion C1, C2 from anterior side. It avoids contaminated corridor. There is a longer and bicortical screw purchase. This is also very important. Your screw can go right up to even beyond the posterior cortical margin, and there is no harm because there is no important structure there. So you can very well take bicortical purchase without any fear of injury to any structure which is posterior to the facet joint at C1 and C2. There is a less bleeding, minimal tissue dissection compared to posterior approach. The posterior tension band, which is very important in stability of the cervical spine, is maintained. So because you don't go from posterior side, therefore the posterior tension band is preserved. There is a less risk of vertebral artery injury, and there is a better patient positioning. This procedure is better because the surgery is done in a supine position with neck extension, very easy. Whereas in posterior approach, you need the prone position with little bit of neck flexion to expose the C1, C2 facet joint. which may cause a little dislocation and cause injury to the cord. So what are the indications? There are limitations and there are indications. So one need to know, not that everything, one single approach can do everything. This is not the way. So the indications are both mobile and the fixed AAD can be treated. So both fixed and mobile, because you can do both things. But the contraindications are if there is a large mandible and if the angle of mandible is below C2, C3 disc space even after the extension and flexion. So in this case, one of our case, you see the angle of mandible was at C4. So this was not the proper case, because to go there, you need a very acute angle and it is very difficult. The ideal approach for any surgery should be orthogonal. Means you should be at about 90 degrees. But in endoscope, even if there is some angulation, but not too much, you can still deal with. So if the angle of mandible is at C2, C3 disc space, this should be here. Then only you can approach safely by trans-cervical approach. If it is higher up, then I go transoral approach, or even some people can go for transnasal. The other contraindications are if there is associated cherry malformation, then you need foramen magnum decompression, possibly from posterior side also. So in those cases, I go from posterior side, decompress the foramen magnum and also fuse it from posterior side. The involvement of facet joint also, if it is there, then you cannot treat, because the manipulation to reduce will not be possible, but you can certainly decompress and fix it in the dislocated position, which is not ideal. This invites degeneration of the lower cervical vertebra. And if there is any other posterior compression, so any lesion which is compressing from posterior side obviously has to be dealt from posterior side. This is a diagram which easily shows you which is the best approach. Undoubtedly, transoral approach is the best approach because it is straightforward. It is orthogonal, 90 degree. So the craniovertebral junction, if you deal with transoral approach, is the best approach. But the problem is you go through the contaminated corridor, so which can be avoided by trans-cervical. But the limitation is angle of mandible. It comes in your way. The rest of the tissue can be mobilized, but the angle of mandible can be mobilized little bit, but not too much. So I'll be telling you how the angle of mandible can be mobilized, and I have suggested a maneuver in which even the mandible will not cause any problem. We can use a large tubular retractor, which I'll deal later on. So these two approaches, transnasal and transcervical, are oblique approach and they provide narrow corridor, whereas transoral approach is the best, but it has limitations of infection, which is not very big, because we have done a significant number of patients now, and so far we had only one infection. So X-ray, what should be the workup? You should go for X-ray, craniovertebral junction, lateral view, in neutral, flexion and extension, and open mouth for odontoid process. One should go for CT scan to know the detailed bony anatomy, and with angio to find out the vessel. So you should take coronal cuts and sagittal cut to find out the status of the facet joint. If these are fused, or if the C2 facet is very small, which does not allow the screws to be put in, then you can use the body of C2 or body of C3 for a screw placement. So before surgery, you should be knowing what problems you may come across by studying the anatomy very well in CT scan, bony anatomy, and you can also know about the vessels. So CT angiogram to find out the course of vertebral artery. Sometimes it is high riding vertebral artery, which may come up to the medial marginal C2 facet lateral mass. Sorry. Um, in those cases, putting in a screw there will invite injury to the vertebral artery. At times, even the internal carotid artery may be placed anterior to this C1, C2 lateral mass. So, before surgery, if you know what are the difficulties or what anatomy you are likely to face, then you can deal them accordingly. MRI is the best investigation because it tells you about the soft tissue in a better way, the amount of neural compression as compared to CT scan. And obviously, one need to know the neurological status and the respiratory condition. If the preoperative respiratory reserve is poor, then you have to go for good physiotherapy before you take these cases. Otherwise, you will have very stormy post-operative period. This shows that the relation of internal carotid artery, it may be at times, it is medially located. So if there is a loop of internal carotid artery coming onto the lateral mass of C1 and you blindly use monopolar cautery to dissect the tissue, in that case you can injure this. So one should know where is the location and deal this accordingly. And likewise, even the vertebral artery can be high riding. It can come near the C2 facet joint here. So both these vessels you need to know very well. And the normal anatomy, what is the normal anatomy? At C2 lateral, so the problem in putting in a screw at C2 lateral mass is more than C1. C1 there is hardly any problem. But at C2, sometimes there is a high riding artery and there is a grooving which may involve up to the medial portion of it. So in that case, you can put in a screw here or even at C3 because there is no space for you to put in a screw. You can very well find out that the loop of the artery may be coming in front of a lateral mass. Not in this case, but there are possibilities. These loops may come in front of the lateral mass of C1 or C2. Here it is at C2 level. See, both of them are almost kissing at C2. So this on left side, the internal ICA is on the lateral mass. So these anomalies, if you know beforehand, it will prevent complications. Then there are other vertebral artery anomalies like persistent first intersegmental artery, which may be there and may be coming anterior to the facet joint, or the PCA may be coming arising from the neck and coming in front of it. So you can injure those vessels if you are not careful beforehand and if you do not know what is the situation. There are various other anomalies also. Lot of anomalies are there. Fenestrated vertebral artery may be there. So these you should know. The other important aspect for surgeon, the anatomy is the best guide. If you know anatomy and if you study the anatomy from other authors, it has been described that in majority of cases there is a safe window medial to they have seen what was the distance of um, vertebral artery from the lateral margin of the dura. So this is the cord from lateral margin of the dura to the vertebral artery. Average distance was about 1 centimeter, 9.8767. So there is a about 1 centimeter window in which in C1 and C2. So medial portion of the lateral mask of C1, C2 is a safe area where you can put in a screw, which I'll be discussing later on. So in most cases, the C2 lateral mask may be intact in type 0, but in various grades, it may be encroaching onto even the whole lateral mask. So putting in a screw in such cases here in the lateral mask is impossible. So why try and invite trouble if you know beforehand what is the anatomy and where the vessel going? Then you can put in a screw at C1 and also put in a screw at the vertebra of C3. So another example of high riding vertebral artery, almost whole of the this thing lateral mass has been involved. So people have said that you can drill the lateral mass and mobilize this vertebral artery and then put in a screw. So this also can be done, but you need some expertise in, I think, vascular field before you attempt. So another example of high riding vertebral artery, which you should know before surgery. And the other important structures, not that this approach is very safe. It is safer compared to the posterior approach, but at times, at lateral mass of C1, you may find hypoglossal nerve. And you may find, I have already discussed that you may find the ICA just over this. So if you are not aware, then you can injure ICA and also you can injure the hypoglossal nerve if you use monopolar cautery without taking due care. First you retract, mobilize this vessel and nerve, and then you can obviously, if needed, you can use cautery after mobilizing these. And so it has been seen in many specimen, cadaveric specimen, that the hypoglossal nerve never comes on the medial side of C1. So it is only present in the lateral portion. So if you put in a screw here on the medial side of C1 and also medial side of C2, that is the safe point of entry. And the trajectory you have to decide depending upon the anatomy, individual person anatomy. Then how these studies, anatomical studies done by the previous authors are helpful to you, that you can find out how much is the length of the lateral mass, how much screw you need to put in. So the average length of the lateral mass of C1 is about 17 millimeter. So that means you can put in 17 or 18 or 19 millimeter screw. Even if the screws goes beyond this posteriorly, there is no harm, except that in the superior portion of the lamina, posterior lamina of C1, there may be the vertebral artery. So you direct your screw inferiorly and medially. In that case, there is no problem. But sorry, you cannot direct it medially. The the facet joint of C1, C2 is directed laterally. So you have to put in the screw in the direction of facet. When you put in a screw from posterior side, then you can direct it, you should direct it medially because the orientation is like this. But from anterior side, you have to put in a screw from medial to laterally, about 5 to 10 degree laterally, so that it does not puncture the cortex. So the anatomy you need to know very well. The other aspect is how much is the width of the lateral mass. It is around 15 millimeter. So in the medial half, which is more than about 7 millimeter, you can very well put in a screw. And what is the safe distance from midline to the vertebral artery at C1, which is about 22 millimeter. So again, if you put in a screw on the medial side of the lateral facet, it is safe. Same way, you divide the C2 lateral mass into three half, medial 1/3, and middle 1/3, and the lateral 1/3. So the screw should be either in the medial 1/3 or at the junction of medial and middle third in the superior portion. So medial is safer and superior is safer because inferiorly you may be a high riding vertebral artery. So put a screw here and it should be slightly laterally rotated. Ideally, you can direct it medially, but medially there may be cord and the direction of the facet joint is laterally. So the direction is lateral, therefore you have to direct it slightly laterally, and unless there is a very high riding and the vertebral artery is involving the most of the facet joint, you can put in a screw in majority of them without having any navigation or anything. So this is what I was talking about. The direction, you have to have the proper, if you put in a screw like this, then there will be breach in the lateral mass. So you have to put in a screw in the direction of the lateral mass. From anterior side, it has to be laterally directed. From posterior side, it has to be medially directed. So in workup, we need to know whether it is so-called reducible or irreducible by having a flexion and extension views. And then you can try the reduction under GA, giving relaxant, muscle relaxant for about 10 minutes, and then in most of the cases you are able to reduce it, unless in those cases in which I have discussed that there is something which is preventing the reduction. So if those factors are there, you have to address them, which fortunately most of them are lying anteriorly. So the factors which cause impair in the reductions are also lying anteriorly. So you can deal with those factors and try to reduce. So majority of these patients you can reduce intraoperatively by removing those things. Then you should also understand the anatomy of the facet joint, lateral mass, and the facet joint very well, whether it is fused, whether it is horizontal or vertical, and how much is the size of the lateral mass of C2. Because that is the problem sometimes. Otherwise, C1 lateral mass is quite big and there is no problem, but C2 lateral mass may not be sufficient in some cases. So there you have to use an alternate side. So again, fuse joint and the callus preventing the reduction, such case are difficult. Before surgery, if you know, then you can heal these. I mean, you can drill out the callus, and the anti-contracting tissue can also be removed. Uh, the, the other problem in this approach is the angle of mandible. So there are methods and which you can use, and some of them are just a positioning of the neck. So angle of mandible comes down if you flex the neck. So extend the neck, the angle of mandible moves up. And if you keep the mouth open and put in tube through the oral route, then also it goes some about 1 centimeter inferior. But if you put in nasal intubation, and then you can close the mouth, you can about minimum 1 centimeter cranial dislocation or angle of mandible can be achieved. Cervical traction is one method in which you can cranially migrate the angle of mandible. The other aspect which I think which requires some company to make these tubular retractors small. So if you can use a tubular retractor which can be pushed under the angle of mandible and little wider. So half of this tube is inside, half is outside, and use angle instrument through this tubular retractor. So I think all the limitations of trans-cervical approach can be eliminated. So using the better tubular retractor, this limitations of angle of mandible coming in the way also can be solved. Awake intubation, fixate any movement. You should be very careful, and if the resident is not experienced enough, you tell them that it's a mobile AED. Hello.
Yes, sir.
It is coming, or
Yeah. Only for few seconds it did not come. Now your voice is clear.
Okay. So awake intubation, and the head in the beginning can be turned to the opposite side as shown here, but after the exposure, it should be in the neutral position. Once you achieve a full exposure, then you bring the neutral position. And the incision should be about 1 centimeter below the angle of mandible, because marginal mandibular nerve can come up to 1 centimeter. Usually it does not come beyond below this 1 centimeter of angle of mandible. So the incision, and then there are definite landmarks of marginal mandibular nerve. It is about 3 centimeter away, at about 3 centimeter away from the mesenteric tuberosity. You will find that the marginal mandibular nerve, it crosses the facial artery. So there you can identify and say, and this usually goes above. There can be more than one marginal mandibular nerve which should be saved, otherwise the angle of inferior lip may get deviated. Submandibular gland can be mobilized, but we did not find any problem in endoscopic approach. This may be a problem in an open approach. You might have to mobilize the glands significantly, but in endoscopic approach, we did not do anything with the submandibular gland so far in any of our cases. The other important structures which may be coming, which the anatomy which is coming in your way, is the posterior belly of digastric muscle. So release these bellies at the attachment to the hyoid cornu, and these can be mobilized superiorly. The hypoglossal nerve also comes in your field. It should be identified and should be mobilized. It is said that the hypoglossal nerve crosses the internal carotid artery about 1 to 3 centimeter above the bifurcation of common carotid artery. So this is one landmark, or otherwise it is usually posterior to the posterior belly of digestive. So just behind you will find the hypoglossal nerve. You don't have to dissect it inferiorly, you just dissect and then push it cranially. So there is no problem. At times you may find a lingual artery in the field which may be coagulated, cut or tied and cut, or can be mobilized. So these are the various digestic muscle, hypoglossal nerve, lingual artery, and the facial vessels usually do not come. These are at the higher level. But if there may be a crowd or abnormal course, if you come across, you can also mobilize them superiorly. And I have already dealt that hypoglossal nerve is usually, it's an important landmark. It crosses anteriorly at the level of ICA about 1 to 3 centimeter above the bifurcation of common carotid artery. The prevertebral fascia is cut and dissected, and so until now it is all microscopic work or naked eye work. I prefer microscope, but after that you need to put in an endoscope. So we have used initially breast endoscope because we did not have EasyGo. It was not available. After the availability of EasyGo, now I am using this set. Although other tubular retractors are also equally effective. Because here the bimanual dissection is better, control of bleeding and everything is better compared to putting in instrument through a limited working channel. So a tubular retractor without any restriction of angulation is better. Now, after this, you should identify the level by using a C-arm and also just by the convergence of longus coli. The longus coli attaches onto the anterior arch there. So anything which is this muscle attaching here has to be C1. Then you can also find out the facet joints, identify them laterally, or if you have any doubt, you use C-arm to find out where is C2, C3 disc space, and which one is C1, which one is C2. So use C-arm if you are confused, or otherwise, once you have sufficient experience, then even watching the anatomy also you know where you are. One should use Govt piece cranially, caudally, medially, and laterally. So this is a picture of breast endo. So earlier picture when we did not have EasyGo system. So Govt piece on one side, superiorly, inferiorly, medial, using a insulated monopole cautery. You cauterize, detach the longus coli from C1 anti-arch, and also medial part of the longus coli from both sides. You have to coagulate. But I have already told you that you should be very careful about the internal ICA. Sometimes it is medially angulated or maybe a loop there. So if it is there, then you bluntly dissect first and then coagulate under vision safely. So medial part of the longus coli muscle is coagulated or removed so that you can identify both the facet joint on either side, C1 anterior arch superiorly, and C2 whole vertebral body and the lateral mass also. So first, before going in, you must identify the anatomy. Don't do anything unless you are sure what is what. So identify C1 anterior arch, identify the vertebral body, C2, C3 disc space, mark the midline at C1 and also at C2, C3 disc space, and identify the lateral margins, and should be both the facet joints should be exposed for good decompress. So again, repeating, you should know if there is a careful about the ICA and the vertebral artery and the anomalies. So this is important. So before you further proceed, you identify at least three structures. One is anterior arch of the atlas, and where is the midline. In endoscope, as you visualize, only a portion of the structures. I have already discussed in avoidance of complication that you see only a part of the structures. Like if you have to identify a person by looking at the eyes may be difficult. So de-zoom and identify all the structures, anterior arch of the atlas, mark the midline of C1 arch so that you don't get disoriented later on. Mark the midline of lower portion of the C2 vertebral body. Also mark or open the facet joint on either side. So you know all these three structures and then you proceed. Remove the all contracting tissue anterior to this, open the facet joint, and then insert a curved curette or a osteotome in the facet joint and try to manipulate and also mobilize. You can push the anteriorly dislocated C1 arch, which most of the time C1 is anteriorly dislocated. So you can push the anterior this thing. You use osteotome to, curve the osteotome so that it causes dissection of C1, C2 facet joint, and most of the time it is reduced. And also position your this thing neck in such a way that it reduces, and then you identify. So once you have manipulated the facet joint and remove all contracting tissue, remove all disc material from the facet joint, and using the leverage action of osteotome or curved curette, under fluoroscopic guidance, you will be able to reduce the C1, C2 dislocation. So if it is reduced, then you just put in a graft there in C1, C2 on either side and fuse those. Or in mobile AD, you just have to open the C1, C2 facet joint, put in graft, and then use C1, C2 lateral mass screws, and that's all. But if by all manipulations and mobilizations of joint and C1 anterior are pushing it backward, if it is not reduced in very small number, in those cases you can, if the facet joint is sclerosed or callus formation is there already in the joint, so in those cases, unnecessary try to dislocate position.
Sir, we are not getting your audio properly.
Okay. So I think I changed my what?
Yeah, now it is okay, sir. Now it is okay. You can come slightly in front of your laptop because audio was low.
Okay.
Yeah. Now it is okay. Yeah. Yes,
Okay.
please.
So what I was talking that if
Yes.
it reduced, then you can put in just screws in C1, C2 lateral mass and put in a graft there. You can use the spacers also. I use just bone graft. But because my patients are poor, they cannot afford these too much expensive implants. So if you put in a spacer also, that will cost something. So I use graft, and I feel that even using a graft is good enough because the chances of the infections are much less if you don't use too much of foreign bodies. Then if it is not reduced, then you have to go for odontectomy and also removal of C2 part of the C2 body until there is a good decompression, and that is decided by Wokenham line, which I think I have discussed, or it is there in subsequent slides. So if it is not reduced, then decompression can also be performed in the same sitting. This slide shows the facet joint, and so not only open the facet joint, but you also drill the facet joint so that the fusion is good. The end cartilage you remove it so that the bone graft you put in will nicely uh, get incorporated, and there will be good bone infusion because the plate and screws will not stay for very long period. So ultimately you have to go for bone infusion. So the facet joint is all drilled. This is C2 side, this is C1 side, and this is the posterior margin of the facet joint. So whole facet joint you should visualize, and you should drill and put in a graft in this. So after that you impact the graft in the facet joint. So this is the graft. This is the drill which has been made in C1 and C2. So the graft has been inserted inside the facet joint. You should know the anatomy and the direction I have already discussed. And individual anatomy. Again, the screws should be on the medial side of this facet joint. Here, about 3 to 5 millimeter inferior to the upper surface of this lateral mass. And again, this is about 3 to 5 millimeter superior to in C1 lateral mass on the medial side, not on the lateral, because there you may come across vessels and nerve and angulate them accordingly. So first hole should be done at C2 because there you find the very less space. You have already supposing put in a plate and so the hole of the plate may not be exactly at the place where you want to make a hole in the lateral mass. So first hole should be in a more difficult place, that is C2 lateral mass, which has a less space compared to very big space, uh, very big lateral mass available of C1. So drop the tube because these plates are wider than the working channel of descendo or even easygosis. So drop them obliquely. First, in descendo you have to take out the inner tube and then drop the plate, and then make this hole and tie the. So this is when screw being inserted, and and after the screw is fully inserted in C2. And after that, you rotate the your plate, and at C1 you make the hole, and after that put in a screw. So screw insertion at C1, which should be laterally directed about 5 to 10 degree, and cranially. It has in trans-cervical approach, you cannot go caudally. The ideal trajectory for me, I think, is one should put in a screw at the superior portion and then angulate it inferiorly, but that trajectory cannot be achieved because of the angulation of the corridor. Because in one case, we had the screw going in the posterior fossa. If angulated cranially, it can go. It was a larger screw, and we did not, the radiology paraoperative did not suggest. The screw was slightly in the posterior fossa. So that should be prevented. The screw in C1 lateral mass body, yeah. So if it is not possible to put in a screw in the lateral mass of C2, then you can put in a screw in the C2 body or C3 body. If decompression is required, then you drill the odontoid process, various stages of drilling of the odontoid process and body of C2. And at the end, you will find a nicely decompressed thecal set. One should not disconnect the tip of the odontoid process completely. You can disconnect partly. So from one side, you can go like this, remove. But if you disconnect it totally, then this tip may migrate upward or may become unstable. So this is what the amount of decompression, how much odontoid and C2 body should be removed is decided by the Ockenham line, because the cord has to go smoothly from here. There should not be any kinking, and there should be good dural pulsation. So various stages of surgery, which I have already discussed. This is a short video of trans-cervical approach. This was the case. It was post-operative. Post-operative, you can find that screw in C1, C2, the graft in between the screws well placed, and then after the post-op, when reconstruction also. So this is the soft tissue which is being dissected. So using in the midline, you can safely use the monopolar artery. Laterally, you should go for blunt dissection. So towards the lateral mass of C1 and C2, you should, using a osteotome, you bluntly dissect, and then using a bipolar or monopolar, you cut it and then coagulate. So identify the anatomy very well. C1, C2. Here you can find that this is a C1 anterior arch. Here I am going laterally to find out where is the facet joint. This is C1 lateral mass, should be C2 lateral mass here, and should be the facet joint here. So identify C1 anterior, C2 body, and then the both lateral mass and facet joint. So using osteotome, and then you make a make the smooth margin using a drill up to the posterior most. You can see that one can go up to the posterior most margin of the facet joint under vision, no problem. So adjoining and cartilage should be drilled, and then you put in a graft there. This is C1. After that, you drill the. It was not reduced, so we drill the only part of the C1 anterior arch till you can find the upper edge of the odontoid tip. So I could realize that the odontoid tip has almost come the superior margin. So only the limited portion of C1 anterior arch, rest you can leave, because it is an important part in stability. Now, this case odontoid was separate from C2 body, so this was unstable. So these cases require little more because they will move, keep on moving. So the odontoid process after drilling is being removed using Harrison punch or curette. Now you can realize that it is unstable. Otherwise, it would have come very easily. But then in most cases, if there is a bleeding, then you put in just Abgel. I was not able to reach at the superior portion, so I drilled little bit more of anti-arch. Now you find that this is the transverse ligament, which can be either removed. If you don't feel good pulsation, then you can dissect this cruciate ligament away from dura and then can cut. Now the drill was made in the C2 lateral mass. The graft is being placed. This is the graft in C1. After this, C2 screw and then C1 screw on right side. Here is the decompressed cord, and then similar procedure on the left side, putting in graft there by rotation, and then in the medial part of the facet joint of C2 and C1, the screws are being. So in the end, first you tight the C1 screw, and then the final tightening of C2 screw should be in the end. By doing that, you pull the C2 posteriorly. And the other things which can be done is that you make the convexity posteriorly. This plate convexity should be posteriorly. Towards you, it should be concave. So tight the C1. I mean, put in the screw first at C2, but final tightening, tight C1 first. Otherwise, if you tight the C2 first, then it may become oblique. So the C2 will not come back. Reduction may not be complete. So tight the C1 screw first, and then tight the C2. This is in a child when we did not have any plate, so I used only cervical. So this was the beginning of my surgery. So we use even cervical plates for discectomy, little wider, placed. Not in the superior inferior, but in a lateral position. Means it was rotated at 90 degree, so that the screw of the upper side will come on the right side, the screw of the lower side will come on the left side in a child. But now you have good plates and screws available, and so screws and plates in place. Another case with plates and screws in place. This is the overall diagram. and especially, so you should put in screws at C1, but not exactly made. It should be in the medial portion. This should also be in the medial portion. But if the lateral mass is not good, then you can put in the screws at lower end of C2, or if you are drilling, you need to drill, then you can put it at C3. If there is a difficulty in putting in screw there, then you can put it at C2 or C3, whatever body, but the length of the screw has to be less. So what are the complications? The screw may be there in posterior fossa, which was there in one of our cases out of, I think, more than 50 surgeries we have done. The screw may be there in the canal. Fortunately, it was not there in any of our case. If you direct it too much medially, there may be ICA injury if it is medially curved. So careful. There may be redislocation because these plate and screws are not that sturdy. So rarely, but if you take a bicortical purchase, if the length of your screws are bicortical purchase, then this will not happen. There may be infection, there may be vertical artery injury at C2 or at the superior margin of the
Sir, the voice has gone down.
Okay.
Yeah, now it is clear. Yeah.
Now, yeah, please keep on telling me.
Yes, sir. Yes, sir.
So I'm keeping this very close to my face.
Yes, sir. Yes, sir. Yes, sir.
Because you know that posteriorly there may be, this is posterior arch of the atlas. So superiorly, it may make a groove there, or it may come in front of even facet joint. So you should know the anatomy very well and then put in a screw accordingly. Don't angulate it too much cranially, otherwise it may injure the vertebral artery here, or the screw may go in the posterior fossa. So post-operatively, perioperatively, you should assess the situation, whether the dislocation has been corrected or not, and then assess the fusion at 6 and 12 months. So the important aspect is the angle of mandible is important. If it is too low, then it is not a good case for trans-cervical approach. During surgery, identify all the structures, anterior arch of atlas, especially the midline of C1 and C2, and short or wide tube if you use are better. You must achieve a good decompression. So what is the limit? Usually I go up to the medial margin of facet joint. So if you go up to the medial margin of facet joint, and the other mistake which is commonly done is not to remove the C2 body. If there is, there is no reduction. In that case, you should remove at least 1 centimeter below the facet joint, because the movement is at facet joint. So see the facet joint on either side, at least 1 centimeter away from, inferior to the facet joint. You should go for wide decompression. So from one facet joint medial margin to the other facet joint on medial margin, there should be good dural decompression and good pulsation should be there. Angulation of screws are also very important. It should be individualized, and you should know how much is the depth of the lateral mass before surgery by asking your radiologist, or you yourself go and see in the workstation of CT scan. Put C2 screw first, and final tightening. In the final tightening, the C2 screw should be tightened in the last. Make little convex posteriorly or concave anteriorly, so that reduction of C2 can be achieved by just tightening, and there should be bicortical purchase. So I think if somebody is interested in making a good tubular retractor, a small and wider tubular retractor will allow us to operate most cases by trans-cervical approach, because you can push your tubular retractor below the angle of mandible there. So smaller, and the other advantage of don't use larger tube. If you use larger tube, your degree of manipulation will be restricted. So the angle formed by the two instruments will be very minimal and difficult to operate. Whereas if the tube is small, then you have a very wide range of movement, and the instrument do not collide with each other. The range of movement is much bigger. So to summarize, endoscopic trans-cervical approach is very effective and safe option in selected patients. It cannot be used in those cases where the angle of mandible is coming in your way. The advantages are both decompression and fusion can be done using the same approach. It avoids contaminated corridor as against transoral or transnasal. Longer screw purchase is there, therefore chances of deep dislocation is very minimal, less bleeding, almost in the avascular plane you go, posterior tension bands are preserved, there is less risk of vertebral artery injury, better patient positioning, but there are some limitations like large mandible or angle of mandible below C2, C3 disc is not an ideal case. Oblique or narrow corridor. It is not a straight corridor as against transoral. So ideally the best corridor is a straight corridor. But up to 30-40 degree of angulation may be all right, but if it is very acute angulation, then you cannot work. You cannot do this surgery when there is associated ACM or the posterior pathology is associated, or there is a disease or the facet joint is injured in that case, because the facet manipulation is not possible. So just an announcement that we have this book is ready, Neuroendoscopy Surgery, a comprehensive approach. It covers all the topics of endoscopic surgery in a single book. I found that most of the book were dealing only either a spine or a cranium or pituitary, but we have brought it is almost complete. In another 15 days it will be there in a market with the help of Professor B.S. Sharma sir and my dynamic colleague Dr. Jitin Bazar, who did most of the work. So and I think it is a good book. And we go for this endoscopic training program. Now I am thankful to my teachers for whatever I know is because of them. Thank you very much. So I think now we can take the
questions.
Yeah.
Thank you, sir. So well, I mean, you explained the indications, contraindications, what exactly the thing. There's one.
So I should stop sharing this?
No, sir. There's only, since you said it is one question answers, I'm asking the question answers.
Stop sharing my.
Yeah. So that you can be seen in full.
Yeah.
Please stop sharing. Yeah.
Stop sharing. Okay.
Yes, sir.
So now it is fine. Yeah.
Yeah.
Sir, I think you gave the answer to the question which is there in the chat box. The person Sukriti Das, Dr. Sukriti Das from Dhaka has asked what are the indications and contraindications for anterior approach, trans-cervical approach. You just know in the last sentence you said so many indications and contraindications like that. You may again explain to him.
But I think we must answer again. So most of the craniovertebral junction anomalies can be treated by anti-approach. I also agree that these are also can be, most of them can be treated, those which can be reduced. And there are proponent of people, and it is true that from posterior approach also you can reduce majority of them. But about 10 to 30% of patients in very large series of over 900 patients reported by other authors, they found that satisfactory reduction was not possible. So they need to go from anterior side. The advantage of anterior approach is that both reduction, I mean facet joint manipulation is possible from anterior approach also. It is possible from posterior. So this may be one of the alternative, and I am using only anterior approach since so many years, except in situation where there is associated ACM, where I go from posterior side.
Thank you, sir.
Contraindication for trans-cervical is if you find the angle of mandible is below C2, C3 disc space, you cannot, because the angulation will be very sharp. And then if the pathology in some tuberculosis, if the lateral mass of C1, C2, you cannot use them. So you have to use the occiput and the lamina of C2.
Sir, your audio is decreasing, sir.
Okay. Now?
Yes, sir, it's better.
Okay. I think connection is unstable. So what I do is, should I go for other this thing?
No, sir, we are able to hear now. Please continue.
Okay. So this answers your question. Contraindication is mandible, and if the facet joint is not favorable, it is involved, or if there is a posterior pathology, in those cases you should go from posterior approach. So I don't say that this is the only approach. You can, if needed, if there is an indication for posterior approach, similar thing can be done from posterior side also. Yeah.
And sir, thank you, sir. The next question is from Dr. Muthukumar Madurai from Madurai Meenakshi Hospital.
Sir.
He has asked, what is the diameter and what is the length of C1 and C2 screw, and which companies is being used?
Diameter is 3.5 millimeter, and the length is 17. At times 17 to 19 millimeter is the length. If in the children, if the diameter is less, then we use less length. The company, I think Ratre, or you know it, which company? It is the local made, very inexpensive.
Sir, we are using Geon, sir. Geon plate and then the screws.
Yeah, Geon.
Geon, sir.
Geon, it is not Chinese.
It's manufactured in Kerala.
Chennai.
Kerala, sir. Kerala, Palghat.
Okay. You know better. Yes.
Sir, I hope Dr. Muthukumar, you got your answer. The plate, what we use is Geon, and the screw also we use sometimes local and sometimes from the Geon company. So the next question is from Manoj, Dr. Manoj.
These are self-tapping screws. So at times when we don't have self-tapping screw, then we use the other one also. But it is better that if you use self-tapping screws, it's better, safer.
Thank you, sir. So the next question is from Dr. Manoj Goa. He wants to know how much of odontoid is removed in this approach.
Odontoid, if the reduction is complete by manipulation, then you don't remove odontoid at all. But if the reduction has not achieved, then in that case, the full odontoid along with part of the at least superior portion of C2 vertebral body also need to be removed. Until there is a good decompression, I told that even before surgery you can make out by Wokenham line, that how much the vertebral body, C2 body you need to remove. Yeah.
I think it is answered in because you initially showed the picture of the area behind the Wakenham's line. Everything has to be removed.
Yeah,
So,
and otherwise during surgery, what you will not know where is the Woken line. At least 1 centimeter below the facet joint. And literally you will have one facet joint and another facet joint. So below the facet joint, you should be drilling C2 about 1 centimeter.
1 centimeter.
Yeah.
Yes. Thank you, sir. As of now, we have only 3 questions. So maybe that you can continue with the next session.
Okay. So thank you, sir. Thank you, Professor Muthu Kumar, sir, very senior neurosurgeon, and he is the General Secretary of our NSI. Thank you, sir, for joining. We go and now for another one. So share screen. This was another one. I need to close this. Stop sharing करना पड़ेगा. Sorry, I think some changes were made when I was reviewing before this thing. So it's a large file, may take half a minute or so. Then I'll share my another presentation, trans-oral. Okay, so share screen. Is that all right now?
Yes, sir. It has come, sir.
Okay. So endoscopic transoral management of atlantoaxial dislocation is another talk. I'll briefly talk about transnuval approach, which I don't do. So transoral is my favorite because I was doing it even before endoscopic surgery. So although most of the CVJ anomalies are being managed by posterior approach now, the treatment by anterior approach also can also address basic pathology with the additional advantage of decompression if it is not reduced. Transoral transpharyngeal approach is the most direct approach, as I have discussed, and so therefore it can be used in selected patients. We all know that recently endoscopic approach has been found to be effective, both endonasal endoscopic for CVJ anomaly and transoral also, and the results were found to be quite good. I feel that each approach has its own advantages and disadvantages, and therefore surgeons need to know the various approaches to properly select those patients. Do not always say that it is the only approach available and rest are useless. So I think one can choose appropriate. There are indications and limitations of every approach. So I have already discussed the various causes of irreducibility, because in those cases, the posterior approach is not possible. Although this may not be a very large number of patients where tissue in between C1 and tear arch and odontoid or fused C1, C2 or a contracted tissue anterior to C1, C2, these will all prevent a reduction when you take a posterior approach. Malunion with fibrosis or callus, injury to the facet joint, which will not allow the facet manipulation. So you have to go from anterior side decompression, then posterior side for fusion, or use, if the C1 is spared, then you can use C1 lateral mass and C3 body like that. Or there is less than 50% reduction, oblique joint, severe anterior posterior or cranial dislocations are not amenable to this. And this is the review of literature, not my own series. Professor Goel says that irreducible EAD need to be re-evaluated. This is true, as the anomaly that may look fixed before surgery in flexion extension otherwise, or irreducible on dynamic image, can be surgically reduced in majority of cases. He also does not say that in all cases, majority of cases. So certain percentage do not reduce. In one large series by S.K. Srivastava et al., they found that using posterior approach and reduction technique, certain percentage does not reduce satisfactorily. In another series, they said that about 8% of patients had less than 50% reduction using this posterior approach. Therefore, they require a transoral surgery in that series, which was, I think, quite large study. In another series of Wang et al. Of 904 patients, they found that 30% did not reduce significantly. So they required to go anteriorly in those cases. They went in anterior release, and then went posteriorly again for fusion. But I think even fusion can be done from anterior side. So again, a repetition that transnasal is oblique, trans-cervical is also oblique. Each has advantage and disadvantage. If craniovertebral junction anomaly has associated with basilar invasion or some pathology at craniovertebral junction is extending up cranially beyond the middle of the clivus, then you need to take a transnasal approach. So the bottom line is this what it is called hard palate. So if the lesion extends beyond 1 centimeter superior to the hard palate, then you require a transnasal approach. In transnasal approach, if the lesion is below the hard palate, about 1 to 2 centimeter, then you require a transoral. And I think I found these two approaches are imaginary. You can put in endoscope in the mouth or in the nasal cavity and put in instrument in either of them. So both can be combined. If the lesion is extending up or down, but if the lesion is there in the craniovertebral junction, extending much more inferiorly in C3 or down, then trans-cervical will be better option. For craniovertebral junction lesion, all three can be used. So if the lesion is here, it is a common place to attack either from transnasal or transoral or transoral. So here you can, all three can be used with limitations and the advantage. So indication of transoral for me are only fixed AAD when C2, C3 disc space is below angle of mandible. So only those fixed AAD where trans-cervical cannot be done. In those cases, I go for transoral approach. It can be done in mobile AAD also, but I think looking to the contaminated corridor, one should avoid. If there is no other option, then maybe you can consider. The contraindication is if there is a posteriorly something like cherry malformation or a posterior compression, or if there is involvement of facet joint by trauma or disease, or the lesion is extending above the hard palate and below C2 inferior margin. When more inferiorly, it is not good option, and superiorly beyond 1 or 2 centimeter of hard palate up to middle of the clivus you can reach transoral. Limitations are if it is an intradural lesion, so strictly midline extradural lesions are better approach. Lateral extension, if it is beyond the lateral mass, then or the vertebral artery lateral to this, that should not be addressed. The workup is same, X-ray, CT scan, and you should know in coronal and sage cut, you should know about the facet joint, and the vascular anatomy should be well known. The MRI is the investigation of choice because it tells you about the soft tissue better. For bony anatomy, you go for CT scan, and with CT you can get an angio also. So we get a MRI and CT angio to find out every detail and also assess the, again, to check the mobility, only irreducible atlantoaxial dislocation where the angle of mandible is below. In those cases, you can go for transoral approach. Facet anatomy, horizontal or size of lateral mass, one should see. I will not go into the detail how to identify this. This is very important. C1, C2, it has dislocated. I think rotated case, while the other side, left side is normal. So this is abnormal, and whether it is horizontal or vertical, you can see in the size reconstructed, or even in the coronal also. Sometimes these are vertical joints. So for this, you get a plain X-ray, flexion extension, transoral view, CT, MRI, irreducible, intraoperative try to reduce and joint manipulation. If it reduces, then fuse. If it does not, then depending upon whether there is a dorsal or ventral compression, you take the dorsal approach or ventral approach. The anterior approach, which approach you should choose depends upon the extent, whether it is above or below the hard palate, or the relation of angle of mandible. If the angle of mandible is too below, then you cannot use trans-cervical. But transoral is almost always possible in any craniovertebral junction anomaly. So this is the best direct approach, with the limitation of possibly infection, fuse, and a callus preventing this. In those cases, the normal joint, the screw placed in C1, C2, and a graph. Professor Jain also nicely told how to look a normal facet joint and abnormal facet joint. It should be studied very well. In one of our cases, the vertical joint. So these are difficult cases. C1, C2 vertical joint.
So your voice is getting deteriorated, sir.
Okay.
Okay, now it's better, sir. Yes,
Now,
better, sir.
so vertical joint. These are difficult cases and difficult to reduce. Preoperative images, vertical joints, too much of compression. One of our case. Another case, angle of mandible was lower, so we took. And what is the extent of decompression one can do? Imaginary line starting from the lower teeth to the hard palate. So usually it is middle of the clivus. And another line coming from lower upper teeth to the imaginary line after the retraction of the tongue. So you retract the tongue and it is usually up to C2, C3 disc space. Laterally, you should go for good decompression up to the medial margin of both facet joints in the vertebra. So usually if the lesion again above the hard palate or 1 to 2 centimeter up and down may be all right, but too much superior from hard palate, you cannot go from transoral, or too much inferior 1 or 2 centimeters below, you cannot go from transnasal. So this is nasopalatine line which decides whether you can do or not. Operative technique, supine position, slight neck extension or neutral position, cervical traction is used. Endotracheal tube is placed on the left side of the oral cavity, and the operative technique is same as that of the microsurgery. So this is the position. Some sandbag has been put below the shoulder so that the neck extension can be achieved. The monitor is just opposite. It is important. If you keep too much cranial or caudal, then your neck will pain. So it should just, surgeon is standing on right side, the monitor should be just opposite you on the left side. And then with the telescope holder and long telescope, 30 centimeter telescope I use, the telescope holder is on the left side, so that both of your hands are free. 30 centimeter long scope is better because if you keep only 18 centimeter, then this arm of your holder and the camera will come in your way. So the long telescope is important rather than 18 centimeter endoscope. Now, infant feeding tube is put in through the nose and then it is tied onto the uvula, then it is pulled back so that some space is created. You retract the soft palate in the nose. Then infiltrate the posterior pharyngeal wall using Xylocare and adrenaline. Also keep a gauze piece and pack the oropharynx. Otherwise, secretions or blood from here may go in the trachea. So pack it very nicely. This is an important step to prevent aspiration. And the incision, you should stay in the midline. So always keep on watching the incisor middle for midline, and don't rotate your the neck of the patient. So maintain the midline orientation. Telescope is there in the center, and both the instrument suction or drill or any other instrument can be passed from left or right or from the inferior or superior side. The exposure, I told you, in any pathology you must identify the anatomy. So exposure, you can identify the clivus if it is basilar invasion, but if it is just a simple AAD, then just expose the C1 anterior odontoid and the body of C1, C2, and laterally up to the C1, C2 facet joint. So this should be your exposure. Identify the anatomy, properly, bilateral C1, C2 lateral mass fixation can be achieved when you remove the disc material and then manipulate these joints using osteotome or a curved curette and using manipulation of lateral mass, especially pushing the C1 uh, lateral mass posteriorly will cause reduction. Because you have already removed the anterior soft tissue which is there in front of C1, C2, and the facet joint has been opened. So majority of these cases they reduce. At times there may be some soft tissue in between C1 anterior arch and odontoid process. So that also can be using an angle drill. You can remove it and maybe you can use a little curved curette. So after that you can try a reduction. If it is reducing, then you can put in just screws, bone graft and C1, C2 lateral mass screw. If it is not reducing, then go for odontectomy and C2 vertebral body excision part of it at least, or whole depending upon how much is required. And then you go for C1, C2 fusion. So decompression by excising the part of C2 body above the vacuum clival canal line is important and should not be any kinking of the cord. So sometimes if you go for incomplete decompression, either inferiorly or on the lateral side, then these patients will not improve. So laterally, your bone decompression should be up to the medial margin of facet joint. Or you should be able to identify the lateral margin of the dura and the cord should be pulsating well. The lateral decompression just beyond the dural margin or just medial to the facet joint. The amount of decompression is shown here before surgery. These are the various steps of surgery, but I'll show the video. So this was even decompression and fusion. Not a difficult case, but it was not reducible simply by flexion extension. So infiltration of xylocaine in the posterior pharyngeal wall. The uvula has been retracted superior. This is cranial side, left side. I am standing on the right side of the patient. This is posterior pharyngeal wall. The endotracheal tube is on the left side fixed, and this is the tongue retracted. So infiltration of the posterior pharyngeal wall. Now using a stab knife, but you should always stay in the midline. Can take help of naked eye, and then otherwise sometimes the telescope is angled and you may not know what is happening. So now the soft tissue anterior to the C1, C2 is removed. Also, you should make sure that there is no medial loop of ICA or vertebral artery has no loop or anything, or not high riding vertebral artery. So same thing as we have seen in the trans-cervical approach. Expose the C1 anterior arch, C2, and then the lateral mass. I'm trying to remove the C1 anterior arch, which is difficult, so you have to drill. So, but partially you can drill, and you can. This C1 is very important in the stability. So, if it is not required, a spare part of the C1. If it is required, then whenever is required, you remove it little bit. Then if you find that you are not been able to reach the tip of the odontoid, process, remove it a bit more. So now the odontoid is being removed, drill. And so I think I can skip those. These are same. This is the odontoid that we done. I think the lateral mask on the left side, yes. In situ lateral mask, the screw has been put in C1, and on ipsilateral side also, after putting in a graft, bilateral screw C1, C2. And we keep the betadine for about 10 minutes. After this, hoping that possibly this will prevent infection. Because that is the only fear. After that, you close the posterior pharyngeal wall very nicely in 2 layers. So good closure is important. Okay. So the advantage of endoscopic transoral approach is it is most direct, effective and safe. Palatal splitting is not required, or prolonged retraction of palate even is not required. Can be done when the oral opening is as small as, here it is written 1.5 centimeter, but maybe even less, 1 centimeter. As compared to minimum of 2.5 centimeter in microscope. Surgery can be done in any neck position, flexion, extension. If somebody has already done a fixation, then using an endoscope, the position of the neck does not matter because the endoscope gives you angulation. It gives good exposure from lower clivus to C2, C3 disc space quite effectively. Limitations is that there is a contaminated corridor, theoretical risk of infection, difficulty in closing the dura if there is a dural tear, and some of these patients complain of difficulty in feeding in the early post-operative period, which has been claimed to be less in transnasal approach. This is the comparison Dr. Pillai has done using a microscope and an endoscope. So in endoscopy, the area of surgical exposure was much more superior compared to the microscope, which we all know because of the angle visualization. You can use 30-degree, 70-degree scope. So visualization is not a problem, but working in an angled field may be a limiting factors. But once you can visualize well, you can do well also. So better exposure of the clivus also. In microscope, very limited clival exposure, whereas in endoscope, about 1 centimeter of the inferior clivus is visualized very well. The results are good. It is effective and safe in our own experience. Transoral approach without fusion was used by Professor Mazhar Hussain and many other people, and they found that it is quite useful. Sorry, some okay. There is a risk of infection, but it was seen only in 1 case out of 63 cases. Redislocation is possible. These are some of the advantages and limitations of various approach: endoscopic transoral, endoscopic endonasal, and microscopy. In transoral, it is most direct, effective, and safe. Palatal splitting not required. Can be done when the oral opening is as small as 1 centimeter. Surgery can be done in any position, inflection, extension, uh, and it provides a wider exposure as compared to um, microscope, microscopic transoral. Endonasal also has some advantage. This is also minimally invasive. Early feeding is possible because the incision is at a higher level in the nasopharynx rather than oropharynx. Palatal splitting again not required. Tongue edema not there. Can be done in any mouth opening. Can be done in any neck position also, even if the patient is on halo jacket or immobilized. Um, Posterior fusion or anything has been done before. Can be done in any neck position, and it has been said that the chances of infection are also less in endonasal as compared to an oral approach. Microscopic, the area of exposure is little less, may require palatal splitting because of the visualization problem. But there are limitations also of endoscopic transoral watertight dural closure. It's difficult, but now you have good glues and maybe stapler uh, or this thing. So it can be majority of times the dural here is very, if it is very rare otherwise. If it happens, then it is just a puncture. So you can use glue. So this is not an issue. There is a risk of infection, potential risk of infection. Um, Transnasal also, the disadvantage is narrow corridor and oblique corridor. The caudal exposure is limited by the hard palate. Very difficult to access structure inferior to this line, that is hard palate, watertight dural closure. Again, you can use tissue glue. In microscopic surgery, there are limitations. Watertight exposure is limited by the extent of mouth opening. Superior exposure is limited by hard palate, mandible, and the base of the tongue limits inferior exposure. Palate need to be split when there is a basilar invasion, resulting in velopharyngeal insufficiency and palatal dehiscence, upper respiratory tract infection. But this is a issue. One must only remove tube when the anesthetist is confident about the airway. If there is any swelling, then you can keep the tube for 1 or 2 days. Although easy to visualize, but by endoscopy, but difficult to dissect. If you keep angle, it is regarding the transnasal and trans-cervical. So orthogonal approach is better, 90-degree. So transoral approach provides most direct and 90-degree approach. So practical tips are that you should remain in the midline. Procedure is indicated mainly for midline extradural pathology. Cranial dense migration, if you disconnect it from the base of the, from the base, care should be taken during anesthetic intubation. Uh, in a mobile AED, you may harm or awake intubation, and during extubation also, and you should be careful in extubation. Only extubate when you think it is proper, after proper assessment of the airway. So to conclude, endoscopic transoral discectomy and fusion is a direct, minimally invasive technique which is safe and effective. Angelo provides better exposure of clivus and the full C2 body. Bilateral splitting not required, can be done when the mouth opening is very small. These are some of our articles. You can read for detail, and the book is coming after some time. Thank you very much. Thank you.
Thank you very much, sir. It was quite elaborative, and thinking you explained what are the advantages of disadvantages of endonasal or transoral and then trans-cervical in one slide comprehensively. I think people have understood it very well. That's why there are no questions, further questions in this episode. Sorry, sir, one question has just come. Just a minute, sir. One question has just come.
Okay.
This is from Rakesh Shihad, sir, Ames Rishikesh. He says, very nice and informative presentation, sir. It covered all aspects of anterior aspects of approach to CVJ. He is thanking you, sir. Otherwise, sir, there are no further questions.
Sir, there are some questions, sir. I'm posting.
Yeah, please post them. So again, Dr. Professor Muthukumar from Madurai is asking, is there a risk of erosion of posterior pharyngeal wall as the result of exposure of implants?
We found one this thing, sir, because this plate and screws are not, you see, these are different from the posterior approach where you have head. There is a head of the screw also quite protruding. So these plates are just flat, and the screws are also they go within the hole of the plate. So unless some screw comes out, there is, I think, almost no risk. We have not come across any exclusion so far. But redislocation was there in one or two cases.
Thank you, sir. I think it has answered Dr. Professor Muthukumar's question. So one senior Air Commodore from Armed Forces is asking, I mean, rather he's complimenting, it was an exceptional webinar. He's congratulating you, sir, for this a wonderful presentation. He says, each of our webinar opens our mind and then more possibilities. Warm regards. So this similar thing has been expressed by one of the senior surgeon in Dr. Pragnesh Bhatt from Aberdeen. He says, excellent presentation as usual. Sir.
Regards. Thank you. Thank you. Thank you, Pragnesh, sir. Thank you.
No more questions in this, sir. Santosh, any more questions?
No, sir. There are no more questions.
Okay, sir. Thank you, sir. Thank you so much, sir, for explicit explanation and detailed discussion. Thank you, Dr. Lucano.
Thank you, Professor Swamy. Thank you, Professor Yadav.
Yes, sir.
Excellent.
Thank you, sir.
Answer.
Yes, sir. Thank you all.
Angelo, I think, yes, Angelo, thank you very much for your presence, and it encourages us. Thank you very much. I hope.
Thank you, Professor. Thank you, overall. Thank you.
Yes, sir. So thank you all the audience for joining this webinar, and very soon will we announce the episode 7 of Professor Dr. R Yadav's Endoscopy Neurosurgery series. I'm very happy to.
After I think 2 weeks, but I think maybe on Saturday or Sunday or weekend we don't keep, because there are others webinar also, and I was interested in some of them. So it is a disadvantage for me. So can we keep on some other days like?
Yes, sir. Yes, sir.
Friday also can be a good day, sir.
Friday also more.
Yeah. Friday evening can be a good day and time.
Okay. So we can keep Friday, no problem.
Yes, sir.
Yes, sir.
Okay. Thank you.
Yeah.
So thank you, sir. Thank you. Thank you all the viewers. I hope you have enjoyed this session. And
yes,
you're most welcome to join us again. As we have discussed, we will shortly announce the date, and you're most welcome.
Yeah,
thank
Santosh,
you, sir. Thank you.
How many logins today?
Sir, very happy to share that 461 login today we got for this webinar. And from 9 countries, 29 neurosurgeons have been attended this webinar.
Okay.
Yes, sir. And I would like to special thanks to Dr. Angelo Lucano for joining this webinar. And special thanks to Dr. Narayan Swamy, sir, for his wonderful coordination of this webinar. So all the audience, just we request you to support for our health and innovative products. And this webinar will be available on DigiNeuro channel tomorrow by tomorrow evening. So requesting you to just subscribe our DigiNeuro channel so you can get the next update and whenever we upload the webinars on this channel. So
Sir, thank you. Sir, once again, thank you very much for enabling us to carry your webinar, sir. We are very, very grateful to you.
Thank you.
Dr. Yadav, sir, thank you very much for enabling us to carry this webinar. Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, Dr. Narayan Swamy. Thank you very much for coordination. And thank you, Dr. Lucano, for making your presence felt in this webinar. All the way from Italy. Thank you very much.
Thank you.
Thank you, sir. With this, sir, we are closing this webinar.
Okay, have a
Thank
nice
you, audience.
weekend.
Thank you, audience, for coming in large numbers. Thank you.
Wishing them all have a nice weekend.
Yeah, have a nice weekend to you also, sir. Take care.
Thank you.
Angelo.
Thank you, Professor. Thank you for all.
Thank you. Thank you.
Thank you. The gag.
Thank you. Thank you. Yeah.
Thank you. Thank you.